this, we're taking 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 with a pinch of salt.
Dear listeners, ladies and gentlemen, welcome to A Pinch of Salt, a new podcast by the ERA. My name is Andres Kubanet and I'm your host for this podcast. We are recording this at the ERA Congress in lovely Stockholm on May the 25th, 2024. With us today is Mathias Haarhaus. He's our colleague from Sweden, a local. It is an honor to have you with us today, Mathias. Welcome to A Pinch of Salt.
Thank you very much. I'm really honored to be here.
We're very happy to have you here for a difficult subject. So Mathias is a nephrologist from Sweden and he's currently the chair of the ERA CKD-MBD Working Group. And obviously CKD-MBD will be the topic of this podcast. And I've been very excited about this podcast since the beginning of the production of this podcast series. Because CKD-MBD, I must confess, is the field that I have the biggest trouble in understanding ever since I was starting as a resident. It contains some ideas that I find hard to reconcile with the basics of endocrinology as we have been taught in medical school. But before we go into secondary hyperparathyroidism, maybe we should start by explaining the basics. So what is CKD-MBD? What does that all encompass? What's the basic problem of CKD-MBD? And do we know how to treat these patients?
Two wonderful questions, two very big questions, I would say. So
yes, I'm sorry.
Let me try to give you an answer. Yeah. Yes, so to answer your first question, CKD-MBD is a term that was developed by KDIGO. Actually, it was almost the inaugural action of KDIGO when they started out in the early 2000s. They approached the mineral disorder seen in patients. Almost every patient has these mineral disorders, and they also approached the evolving knowledge that mineral disorder, cardiovascular disease, and bone disease are somehow linked. Mm-hmm. And they termed the syndrome they identified as CKD-MBD. So it consists of bone disease, it consists of mineral derangement, so laboratory, and clinic. And the clinic is mostly fractures and cardiovascular disease. Mm-hmm. From that, we have traveled a long way.
Okay.
We are still discussing it, and I think we do shift the focus today. I think one of the focuses they had back at that time was laboratory. We are still treating laboratory, but and this may be one of the side effects of the early term, that we have been focusing far too much on the laboratory. Mm-hmm. I think what we're doing today, and we have just had a new controversies conference last fall. What we're doing today is we are shifting back to the patient. We are looking at the clinic.
So to put it very simply, we're trying to prevent bone disease and fractures because of it, and vascular calcifications and cardiovascular outcomes from that. That's the basic goal, right?
I would say that sums up CKD-MBD.
Okay. But it's a huge set of different pathophysiological circumstances, I guess. It's not one disease, probably.
Very good question. So I think the question always comes up, is it still a syndrome or should we split it up? Mm-hmm. It's very complex, it's getting more complex, but I think the mineral is still at the basis, so how the body is handling the mineral. And we are learning more and more about what different mechanisms the body has developed to control the mineral. And we are also learning why. So that's why the bone is very important. That's why the vasculature is important.
Yeah. So for a long time, in my mind at least, I was probably wrong, but in my mind, for a long time, CKD-MBD was somehow synonymous with secondary hyperparathyroidism in a way. And the focus was on parathyroid hormone. And the issue I had with that is I couldn't really understand the physiology, the pathophysiology behind that. Because on one hand, we have high parent hormone levels in dialysis patients in particular, but normal or low serum calcium levels, which would then suggest some form of parathyroid hormone resistance. That it might be high, but the biology of it isn't successful, isn't working. It might be, its effect might even be lower than what one would want to have. So why was then our main target to lower parathyroid hormone levels if maybe the resistance is the key issue? Because we can compare this, it's not a perfect comparison, but we can compare this with, for example, insulin. And diabetes type 2, particularly in the initial phases where you have insulin resistance, if you would measure insulin, it would be high, but because it's not effective enough. And of course, the mortality of patients with diabetes type 2 is high, and you would see that with high insulin levels, you would have high mortality, which would imply, okay, we want to lower it, but of course we know the biology is not right, so we wouldn't do that. It would not make sense. We actually give insulin. So there's a bit of a conundrum here. How do you see this? Are we too focused on parathyroid hormone?
I think parathyroid hormone is probably, I'm not a diabetician, but it's probably more complex. The parathyroid hormone resistance we see in the bone is a very complex phenomenon. And if we focus too much on that physiology, maybe we get entangled in something where we treat laboratory values and we don't treat the patients. So I think we should turn back from looking only at the laboratory and turn towards the patients and see what are we doing to the patients to improve clinical outcomes. So and we know, of course, and there we have clinical data, we know that very high parathyroid hormone levels are harmful to the patient. We know also that in certain situations, very low parathyroid hormone levels are harmful to the patient. But low parathyroid hormone, so a suppression, is actually something that we can induce. So oversuppression of parathyroid hormone can be harmful. If we turn and look at the bone itself, we can say, well, does low bone turnover per se harm the body? And probably it doesn't, because what we do with, for instance, fracture prevention, so anti-resorptive treatment, we are lowering bone turnover to a very, very low level, both formation and resorption, but we do not harm the patient. Actually, even if you look at the cardiovascular signals in trials, they are not negative. So probably if we talk about the low bone turnover, we have to look much more at the reason why a patient has low bone turnover. Yeah. And I think one of the most dangerous reasons is malnutrition and inflammation. So if you have these combinations also in diabetes, which is of course a very special situation, then I think the low bone turnover can be harmful.
Also probably sarcopenia and low mobility, right? So
yes.
So a low bone turnover is more of an indicator of an unfavorable situation, more so than a problem for the bone itself.
I would say so, yes.
Because I thought simplistically years ago that maybe low bone turnover is a problem because this calcium that is not going into the bone will go into the vasculature, but you're saying that that's not really a huge issue, if I understood you correctly.
Well, a few years ago we were giving very high calcium doses. We have moved from that. And I do believe that these very high, giving several grams of calcium, is in many situations harmful, can be harmful. I think that we have turned too far in the other direction. I think that we do need to supplement calcium on a lower level. And I think if we give this to a patient, for instance, with fractures in combination with an anti-resorptive treatment, there is not a high risk that the patient will develop vascular calcification. We have some studies looking at that.
That's very good information. That would put my mind at ease about some things for sure. So you said that we know that really high parathyroid hormone levels are detrimental. So what are really high? What is really high? To ask a simple question. I know the simple questions are difficult, but
the simple questions are the most difficult, of course. And I'm sorry, but I have to disappoint you. I don't have the exact level where it becomes harmful. I think what we also have learned during this time, especially since the last KDIGO, or already the first KDIGO recommendations opened up to allow for higher parathyroid hormone.
yeah.
I think what is very important to know is that they did not tell us to lift the parathyroid hormone level to the 9 times upper normal limit, but they told us that if it's there, up to 9 times the upper normal limit, it can be okay. But look at the patient. So I think personalized medicine is very important. And the large span of parathyroid hormone that we can accept in a patient, depending on the whole situation, tells us that this is a hormone that is very active, and we really, really need to personalize parathyroid hormone directed medication or treatment.
You say look at the patient. I'm going to dig in a bit into that. So ideally, probably to determine what's going on the microscopical level, you want to do a bone biopsy. We all know that's beneficial, but we also all know that it's not very commonly done. So let's put that on the side as something that is great, but not always available. So assume if the patient has fractures, or then you know he has or she has bone problems. So what would you do in that situation? To be quite simple, somebody on dialysis who had a recent low intensity fracture, how would you go about solving that, preventing the next one? I would say
I really like how you enter the clinic now, because this is where I come from. I'm a clinician 100%. So yes, and I totally agree with you. We cannot expect to take bone biopsies on every patient where we want to know what is the bone turnover, what is the bone mineralization, and even the volume. So I think this is, if we are looking forward a few years and we expect the new KDIGO guidelines, this will probably be one of the turns we can expect, that we will talk more about how do we clinically manage our patients with high, with low bone turnover, with high or low bone volume, with mineralization defects, and how can we identify them in the clinic. Not golden standard. Golden standard is very important, but we also need to have an instrument that we can use as clinicians.
Yes, exactly.
And I think for, at least for the turnover, we can now say that we have pretty good bone markers, and I'm not talking about PTH, because PTH is not a bone marker, it is a bone regulator.
Yes.
We have pretty good bone markers that we can use to identify the bone turnover of our patients with relatively good certainty. These bone markers are not yet globally available. They are available in specialized clinical labs. I'm talking about the bone alkaline phosphatase, the TRAP, P1MP, and I think what we need to do is, in order to be able to integrate them into our clinical management, we also need to involve the bone people outside of nephrology. So endocrinologists, osteoporosis specialists, people who actually do bone diagnostics. There is a very good consensus within that field to use bone markers. They are much more active than we nephrologists in using bone markers. The unfortunate thing is that when they, some years ago, in a consensus statement, identified what bone markers to use, they used PTX and P1MP. And the non-intact P1MP and CTX are two bone markers that are influenced by GFR.
Yes.
So there's also a new consensus coming, and I do hope that we can expect that even the bone world outside of the CKD-MBD world will look more towards bone markers that are that can be used even in the CKD setting.
So bone-specific alkaline phosphatase and TRAP, for example.
That could be bone markers that may be recommended in the future.
So in a patient that had a fracture and you suspect or you have evidence, circumstantial but still evidence of high bone turnover, what would you do? Lower parathyroid hormone or give anti-resorptive drugs like bisphosphonates or denosumab, or do both?
Yeah.
How do you decide on that?
So I think we still need to see that the very high bone turnover is detrimental, and we need to treat it. So I would look at the PTH level, I would look at the bone turnover markers. I would also look at the DEXA, because we know that very high bone turnover can lower the bone mineral density.
Yep.
And if the whole picture, I would also look at the patient, of course, because symptoms are very important also. So I would look at the whole picture, and do I see that there is a pretty high suspicion of very high bone turnover? I would address that first. But if that does not sufficiently improve the patient's bone, then I think we could go on and give an anti-resorptive treatment once we have gotten the bone turnover.
The parathyroid hormone, in this case, to an area that we deem to be better.
The bone markers.
The bone markers.
I would treat the bone markers.
Great. So you would follow particularly the bone markers to see the... Okay.
And that's, of course, the greatest advantage of using bone markers, because in contrast to a bone biopsy, we can follow them. Exactly. We can look at the dynamics. And bone is a very dynamic organ.
It's like urine in clinical nephrology.
Yeah, there you go.
So if we turn our minds to vascular calcification, we have a patient who's severely vascularly calcified. You see it on x-rays, you see it on CT scans, for example. You know the patient is bad in a cardiometabolic way, let's say. Is there a way to tackle that, or do you just focus on the key issues regarding cardiovascular outcomes in general? How would you, is there anything specific you can do in the CKD-MBD world for vascular calcification, or not yet?
That's a key question, of course. That's a key question. And well, I come much more from the bone corner of CKD-MBD than from the vascular corner. But I must say there have been trials, there have been calcification inhibitors developed, which I think are promising, but we still, the verdict is still out, I would say. Whether we will be able to treat our patients so we can revert vascular calcification. I believe much more that we need to identify very, very early changes in the vessels. And I think for that, we still do not have the ideal diagnostic instruments.
Yes.
So do we see massive vascular calcification? It may be too late to treat. So more dynamic diagnostics. The fluoride PET is a very interesting instrument. Of course, it's an instrument that currently is so rare and also very expensive. So we will not use it for routine diagnostics. But I think we also have lacked the early instruments in clinical research. So if we can identify early changes that lead to the development of vascular calcification, then I think we get closer to treating it and preventing it.
So there's quite a bit of road to travel in that respect as well, diagnostically and therapeutically.
I would say so.
Okay, this has been very illuminating for me, I have to say. So we're coming to the final part of the podcast. I wanted to ask you, as we ask all our guests, basically, or my guests, if you had only one message to give to a young and up-and-coming nephrologist, maybe a message from the field of CKD-MBD, but not necessarily. What would that be? What would you suggest a younger colleague? What would be your main thing you would want to tell yourself when you were younger, perhaps?
So one of the things I would tell is look at your patient. Never forget your patient. Have your heart in your clinical work. And then I would also say, look very well at your patient. Look at the diversity you see. Look at the individual you see. Because I believe personalized medicine is the future.
Yeah. And personalized medicine does not necessarily mean you do genetics for every kind of.
No,
it's just doing what Hippocrates has already was already teaching all those years ago. I guess
definitely.
And you
yes.
and your common sense, perhaps, yeah, and your intuition as a physician. So now to the final, and sometimes that's actually the most difficult question. I hope it won't be, but still, it's a getting to know you question. It's an interesting one because you were able to see the person behind the medicine, let's say. So, which book, 2 songs, and a luxury item would you take to a desert island?
Yes, so that is a difficult question. Number one, I'm not planning on going to a desert island.
Okay, fair enough.
I will have to end up there.
Yeah.
But which?
Let's say you're forced in a way.
Let's say I'm forced. I'm exiled to.
Okay, let's say that.
So yes, that's very interesting. So I must say, currently, I am neither reading a lot of books or listening very much to music because I'm concentrating so much on many other things. My family, among others, but also of course, my clinic and my research. But one of the books I've been most impressed by, and I like to read again and again, is a book by a German author, by Thomas Mann. It's Dr. Faustus.
Oh, yeah. The legendary Thomas Mann. I haven't read Dr. Faustus yet. I read Death in Venice, but he's a master, master writer.
Yeah. Yeah, and Dr. Faustus takes up a very important topic. He wrote it at the end of the Second World War when a country that he, I think, identified himself very much with was more or less imploding and drove him into exile. He never returned to Germany.
True.
But I think it's a very deep discussion of not only the German fate, but also the human fate.
Yeah, unfortunately, extreme situations will give a lot of insight, which you could gain without that too. But thank you for the book. Now for the 2 songs.
Okay, so I think on a desert island, I will long to something that is really beautiful. So one of the songs that touches me deeply is Ave Maria by Charles Gounod and Johann Sebastian Bach. So that would be, it's a classical song, but
that would be comforting,
it would give me calm and beauty.
Definitely.
And then I also need something that is a little bit more lively. Pick me up. And I like the Scorpions. They have several songs. I'm not sure which one I would pick, but Still Loving You, for instance, is a wonderful song. I like that.
That's romantic. And the luxury item? What is something you wouldn't want to live without, even on a desert island?
That is a much more difficult question. So, a luxury item. I would probably need to have an instrument to listen to these songs. So
like a hi-fi system or something.
I would probably have an iPhone would probably not work, but
probably not for a long time. Yeah.
Something that I can really listen to good music with.
Okay, fair enough. Mathias, thank you very much for sharing all your valuable experience, clinical experience and research experience in this difficult field. We see the field is changing. New times are coming, and it's nice to see. And we're very grateful that you took your time for us at A Pinch of Salt. Dear listeners, thank you for listening. And please check out the other episodes that are already available. And have a good time. Thank you very much.
Thank you. It was a real pleasure.